going to go from talking to babies to talking about aging, so the opposite end of the spectrum. But it still takes a village to take care of us as we age as well. So these are my disclosures. So we're going to talk about how aging should impact our decision-making as we're taking care of our patients, because one thing's for certain, we will always be older tomorrow than we are today. And there's some special caveats that we have to think about as we're managing our IBD patients. So the scope of the problem is that older IBD patients do have increased healthcare utilization, and that may be because we have a lower threshold to admit older patients to the hospital. There's a decreased ability to handle the burden of disease activity because of factors such as frailty and sarcopenia that are more prevalent with age, and increased likelihood to seek medical attention. So an older patient may be more concerned about having a few days of bloody diarrhea than a younger patient who just feels like it's due to hemorrhoids and a bad taco. There's challenges in establishing the diagnosis of IBD because a lot of people don't recognize 10 to 15% of new diagnoses of IBD occur after the age of 60, so it's absolutely possible. It's not just a young person's disease. There's also the adverse effects of therapy, particularly steroids and combinations of immunosuppression. Are they at a greater risk of infections, but also serious infections requiring hospitalization? There's also the impact of IBD on pre-existing comorbidities. For example, if they already have a history of cardiovascular disease, if they have a history of diabetes or renal failure and they have chronic dehydration, what is the impact? As well as undertreatment of disease activity, because we tend to take more of a risk-averse strategy to addressing our older patients. So the thesis when we're managing our older IBD patients should be the same as for our younger patients. Early control of disease activity is really essential to decrease morbidity, not only related to IBD, but for overall and other conditions. And early recognition and correction of modifiable variables, some are more unique to the older patient population. And to optimize care in the outpatient setting with appropriate medication use. We have to keep our older patients out of the hospital. Once they're hospitalized, the risk of mortality, worsened morbidity, and things like venous thromboembolism are much greater, including infections like C. difficile. So we also have to think about age-associated physiologic changes as we're thinking about our multidisciplinary care for our IBD patients. Aside from the gastroenterologist and potentially the hematologist as we're doing infusions, who else needs to be part of the team? We oftentimes forget about sarcopenia. Sarcopenia is an independent risk factor for infections, hospitalizations, and post-op complications. It's actually a very easy assessment. It's a grip strength test as well as a get up and go. How fast can they walk? And that measure can actually be modifiable with appropriate nutrition interventions as well as physical therapy. There's also, we have to consider with aging, decreased anal sphincter function, a decreased ability to manage symptoms of urgency, frequency, and nighttime bowel movements. This is especially true for late onset IBD, which tends to present more like an inflammatory colitis. So symptoms like urgency, tenesmus, accidents, continence are more prevalent. So there's a limited role of topical therapies, which may be some of our mainstays for more distal disease. And then also being up all night, that sleep deprivation can actually hasten aging, impact cognition, and increase risk for delirium. This cognitive impairment and hearing and visual compromise that goes along with aging can actually result in increased medication errors, especially as our regimens become more complex. And then age is an independent risk factor for multiple forms of malignancy. So we have to think about risks of uncontrolled disease, for example, with colorectal cancer, but also risks of medication associated with aging, for example, lymphoma. So how is age affecting our IBD patient treatment selection? And we do know that older IBD patients will need maintenance medications. You induce and then you maintain remission. And this is a study that was done by the group at Pittsburgh, and they were looking at maintenance medications. We also know that older IBD patients, especially newly diagnosed, tend to present with moderate to severe disease. Knowing that 5-ASAs are used for mild to moderate disease and steroids are not a maintenance strategy, you can see right away that we are not treating our older IBD patients correctly. In this study, about a third of older IBD patients were maintained on chronic steroids, which is not a maintenance medication that is acceptable in any age group. And you can see, even though many of them had moderate to severe disease, clearly had steroid dependence, there was a low utilization of traditional steroid-sparing strategies. You can say that's a single study. Maybe it's not replicated elsewhere. More studies. This was a Swedish study that was published in Gastro last year that looked at IBD patients who were diagnosed after the age of 60. At 5 years post-diagnosis, there was 60% steroid exposure during the follow-up period, and it was actually greater steroid exposure for this older onset group compared to younger patients. And only 2% and 6% of UC and CD patients were prescribed biologics, slightly more, but not a significantly higher number of immunomodulators. In the EpiMAD registry in France, corticosteroids and 5-ASAs were prescribed more frequently than immunomodulators and biologics. And in that patient population, after 5 years, 45% of their late onset patients were still on steroids, which tells you we're not treating our patients correctly with the right therapies. And part of it is we don't know really what should be our endpoint. Nowadays, there's all this talk about mucosal healing, histologic remission as our goals of treatment. That's our target. But when we're dealing with older onset or people who are aging with their inflammatory bowel disease, do our targets need to shift? Are we more satisfied with clinical versus deep remission, endoscopic improvement versus mucosal healing? Are we more focused, should we be more focused on improving their quality of life and reversing or preventing frailty, which is really what's associated with the poor outcomes, and to reduce disability? But regardless of what our target should be, looking at the risk factors that are associated with IBD therapy, regardless of age, malnutrition, comorbidities, hospitalizations, steroids, narcotics, you can see that 5 of those 6 are modifiable. And so this is what we really need to target as we're addressing our older IBD patients. As you saw, there's a lot of corticosteroid maintenance therapies that are being prescribed. And we all know this, they are not maintenance therapies. There are many steroid-associated complications, and they increase with age. Most importantly, bone loss and serious infections. And this is where we really need to borrow from our rheumatology colleagues. We borrow from them from everything else. We should borrow on how we manage our older IBD patients. And they actually have this criteria that are called potentially inappropriate medications. And they use a stop and start tool. STOP is a screening tool for older persons' prescriptions. And they flag, if they're using steroids for greater than 3 months to treat their RA, they need to use something else, which means they need to start, which is alert the doctors of the right treatment, a disease-modifying anti-rheumatic drug, whether it be methotrexate, whether it be a biologic. And our RA colleagues, our rheumatology colleagues, are far better at prescribing anti-TNFs or steroid-sparing strategies for their older RA patients than we are with IBD. So you can say, fine, that's prednisone. What about budesonide? So mild, so easily available, much better. We can use that as a maintenance. The problem is there's no long-term efficacy or safety data using budesonide as a maintenance strategy, regardless of age, for Crohn's disease or ulcerative colitis. Perhaps it can be used in microscopic colitis. Maybe you can argue that for persistent asymptomatic mild Crohn's disease, you need budesonide. But then you can ask yourself, is it truly, if they cannot get off budesonide because they're still having symptoms, are you underestimating their disease activity, or should they be on something else? Why do they still need to be on budesonide? Otherwise, they're having 10 to 15 bowel movements a day, even if you just see a little bit of ileal disease. Are you missing something else? The trickier thing, I think, are the patients who have 5-ASA hypersensitivity and they truly have mild colitis. Can we maintain them on, let's say, Uceris 9 milligrams daily? The problem is that we only have a singular dose. We don't have a 6 milligram, we don't have a 3 milligram, we only have one dose. And using ileal-release budesonide to treat ulcerative colitis may not be that effective. But we also have to think about costs. Budesonide is not cheap, and they're not always covered by Medicare, and they aren't without risk. Adverse effects can occur in up to 10% of treated patients. So you really have to ask yourself, if they really cannot get off the budesonide, perhaps they need a steroid-sparing strategy. So what should that be? Because we already know there's a low rate of biologic prescribing amongst older IBD patients, and this due to this underutilization of standard therapies. And maybe it's because we're scared to use them, because we don't have enough safety and therapeutic efficacy data for biologics or some of these newer mechanisms of action, particularly for older IBD patients. Maybe it's because we're concerned about cancer risks associated with biologics. We know immunomodulators, such as mercaptopurine and azathioprine, are associated with an increased risk of lymphoma as well as non-melanoma skin cancer, and that risk of lymphoma does decrease once you withdraw the thiopurine. But in general, it seems that our strategy is to avoid adverse events of therapy rather than to actually treat the disease itself, and that's why we're relying on chronic steroids. There's not a lot of great data. There's no prospective randomized controlled trial of patients over the age of 65, and even doing post hoc analyses in the randomized controlled trials are very small numbers. So we have to base our analyses on very small retrospective studies. This was the one that was published a few years ago, where they looked at short-term versus long-term clinical response for people over the age of 65 versus under the age of 65. The group that was over the age of 65 is in the blue bars, whereas the younger patients, less than 65, are in the red. And as you can see, in terms of response, the older patients had lower overall response rates regardless of comorbidity. CCI is the Charlson Comorbidity Index, compared to the younger patients. But if you look at the bottom at that table, those who did respond were more likely to stay in response, were just as likely to stay in response. So if a patient is responding to the treatment, we should continue it. And perhaps this lower response rate is not necessarily because of a mechanistic failure, but delays in starting treatment. Because we know the longer we wait to start a steroid-sparing strategy, the less likely it is to work. So let's borrow from RA, because they're more likely, because of their stop and start protocols, to switch to a steroid-sparing agent. And in this top study, they looked at 107 RA patients, aged greater than 60, and they found no difference in anti-TNF retention rates at 3 years compared to younger patients. So the patients who responded were able to maintain their response. And the more likely reason for older patients to discontinue medications was due to adverse events, whereas younger patients, it was due to lack of efficacy. In this larger Canadian study, they were looking at infection risks associated with immunosuppression, because there's a lot of concern about giving biologics to older patients. And of the 3 different categories they looked at, disease-modifying non-biologic anti-rheumatic drugs, steroids, and anti-TNFs had, while they did have a greater risk of serious infection compared to placebo or not being on them, they were actually lower than DMARDs, non-biologic DMARDs, and certainly lower than low-dose or high-dose corticosteroids. So again, as we're positioning therapies for our older IBD patients in terms of risks of infections, getting them on steroid-sparing agents is really the most important. This is data from the TREAT registry looking at older versus less than 65. I don't know if that's necessarily younger patients. And the biggest issue was IBD-associated hospitalizations, serious infections, and surgeries. And so I don't know if this necessarily translates to a lack of response if they were able to use the medications correctly in the first place. Because once these patients end up in the hospital, yes, they're going to be more likely to have serious infections, and yes, they're more likely to need surgery. So I think this data actually highlights the fact that we're using it too late compared to the actual dangers of the medication itself. This is a study that actually just was published and by Sid Singh, who you heard from earlier. This is a post hoc analysis of the REACT trial. And the REACT trial was essentially looking at an algorithm-based approach to optimizing therapy. And this was a subgroup analysis of the patients over the age of 60. And they had 311 patients over the age of 60, and they compared them to the patients under the age of 60. And the way that the REACT trial was designed is that patients who continued to have active symptoms after 4 to 12 weeks of steroids, they were treated with adalimumab plus something else as a combination therapy. So all patients received combination therapy, and they used a treat-to-target approach, where every 12 weeks they assessed for response or remission. So things to keep in mind as you're analyzing this data that was not powered to look at older patients is that these older patients already had a longer disease duration, they already had more Crohn's disease surgeries, but they had less complicating disease at baseline, less penetrating disease, and less prior anti-TNF use. And basically, what they showed was there was no difference in corticosteroid-free remission, which it wasn't powered to look at. But more importantly, there was no difference in serious complications for this group of patients. And remember, these are patients who were early initiators of combination therapy, not delayed initiators of combination therapy. So the take-home message is, we actually don't know if the early combination therapy approach is preferred in the older patients. That's not what this study is telling us. But it is telling us that there's no increased safety signal in this REACT trial post-hoc analysis with using combination therapy for people who are continuing to have symptoms despite being on steroids. So something to think in mind as you're choosing your therapeutic strategy. So if you have a functional patient who is robust, who's 75 with a new diagnosis of Crohn's disease, not responding to steroids, this may be an option provided they don't have any other signs of comorbidities or frailty. What about some of our other agents? Because vedolizumab is getting kind of the first line status for anybody who's over the age of however you define elderly. But where is the data? So let's look at the pooled analysis of the Gemini UC studies, which defined older as 55 plus, which depending on how old you are, may or may not be offensive. And so the week 6 response rates were 38%, and week 52 remission rates were 42%. But the serious adverse event rates were low, and the infections overall, even though they were higher, very few were serious infections. In another study, they looked at older IBD patients, defined again as greater than 55, and they had lower clinical response rates compared to younger patients defined as 18 to 30. So 15% response rate versus 58% response rate. So if you have a patient who's over the age of 55, who has moderate to severe disease, who's flaring, this is the data that you have to look at. Is this really that much better than the anti-TNF data that I'm showing? In terms of safety signals, you just saw the REACT data for combination therapy, and you saw the previous data with anti-TNF monotherapy. Is the safety signal really enough to drive you to use this as a first-line therapy? I think that we need a few more studies to really help clarify positioning depending on disease severity. Let's talk about ustekinumab and tofacitinib. Even less data for older IBD patients, so we have to extrapolate from other disease states where it's used quite a bit. Psoriasis, 24 patients over the age of 65 were treated with ustekinumab, no serious infections at 1 year. In the RA patient population using tofacitinib, greater than 1,000 patients over the age of 65 were treated with tofacitinib during the phase 3 trials. And they had numerically higher rates of serious infections and medication discontinuations, but the efficacy was similar to younger patients, and the strongest safety signal, no surprises, was zoster. In another smaller study, they noted of 17 patients with a mean age even older of 79, they saw significant decreases in disease activity indices, but a number of infections, most commonly zoster. But we have to go to this FDA warning that just came out. Now, granted, you have to keep in mind this patient population is not the overall IBD patient population. These were patients who were over the age of 50, who were diagnosed with rheumatoid arthritis, who were treated with a higher dose than standard for rheumatoid arthritis, 10 milligrams BID of tofacitinib, and they already had a pre-existing risk factor for major adverse cardiovascular events. And what they saw was that there was an increased safety signal of blood clots and mortality associated with this higher dosing. Now, can we extrapolate that directly to our older patient population? Not necessarily, but it does make you take pause if you have other options that are available. So you always have to view the risks of the treatment with the benefits and other options. But what I will say that also makes you have to consider things as your positioning agents is tofacitinib is also an oral agent, so it would go under Medicare Part D, whereas we have other infusion-based agents that may be billed under Medicare Part A and B. So the out-of-pocket cost is also something to think about when we're talking about risk. So I know I only have a couple of minutes left, so I'm going to try to breeze through some of these slides a little bit more quickly, because the emphasis that I want to make with these last few slides is that while there are a lot of risk factors associated with age, such as all of these right here, many of them are modifiable. So how can we modify these underlying risk factors so that our current arsenal can work better? One of them is vaccinations. We talked about it earlier. Optimize comorbidities, optimize nutritional and functional status, avoid narcotics. Did you know hydrocortisone with acetaminophen is one of the top 10 prescriptions for older patients over the age of 65? Avoid prolonged steroids and combination immunosuppression, and keep older patients out of the hospital. So how are we going to do that? First of all, they have to be able to afford their medications. So this is where you have to think about access to care and costs. So you need to choose agents that are covered. If you lose time trying to get an injectable medication covered, but they can't afford it because Medicare Part D is too expensive, you should have gone with the infusion-based version early on. You also want to cover and correct micronutrient deficiencies, such as all these vitamins and minerals that tend to be more abnormal with older patients. And ideally, you want to try to get them involved with a consultation with a registered dietitian. Now, you can say these services aren't covered. Depending on how creative you want to be, one of the ways to get it covered is chronic kidney disease. Stage 1 chronic kidney disease is a GFR greater than 90. Stage 2 is a GFR between 69 to 90. You code a stage 2 chronic kidney disease, Medicare will pay for that nutrition consult, FYI. So correct anemia. You IV iron, Medicare Part A and B benefit. Much easier to tolerate. If you correct IV iron, anemia with IV iron, it improves functional status, improves physical reserve, and also it's associated with better outcomes, decreased morbidity, mortality, and the likelihood of response to medications is greater. Psychosocial assessments, they actually are covered through Medicare, and you can reduce polypharmacy. Pharmacy consults are covered through Medicare. So many things are covered if you're over the age of 65 through Medicare, you just have to request them. So in terms of correcting anemia in older adults, all of you have this handout. These are the reasons why it's important to correct the anemia in older adults. But remember, Medicare medical benefits will cover all of these. And there are certain formulations that are better tolerated than others. When you're choosing an IV iron formulation, you want to think about the number of infusions and the rapidity of the response. The formulations that you should choose are the ones that are going to correct the anemia with the fewest number of infusions. In terms of physical therapy assessments, we talked about sarcopenia impacting infection risk, morbidity, and mortality. Physical therapy covered by Medicare Part B. You just need to put in a referral for deconditioning. And then the physical therapist then puts in the recommendation for further services. Up to 80% of original Medicare costs will be covered with Medicare Part B and physical therapy. We need to use it. Similarly, psychosocial assessments. Depression is not just a part of the aging process. You don't have to use one of the geriatric depression scales. If you use the PHQ-9, it actually performs very similarly. So if you identify a problem, Medicare covers counseling services. You just need to request it. Medicare medication reconciliation is important. Polypharmacy, multiple risk factors for polypharmacy. The average older adult takes more than 5 medications. And medication interactions and increased risks of infections and interactions with the disease state are very common. So you want to make sure you do medication reconciliation. This is where you can introduce your local pharmacist to help with that. And you want to minimize pill burden and decrease pill complexity or medication complexity. It's hard to really put together a slide about where to position agents. So this is kind of what I do in my practice, and what you're going to see is not on here is tofacitinib, because I don't think we have enough data yet, but also there's potentially a coverage issue. So until we get more data, I think that we do have other potential options. It's not to say that I don't use tofacitinib, but it's something that I take pause about until we get a little bit more clarity about its safety in an older IBD patient population that's already susceptible to blood clots because it's an underlying hypercoagulable state. So in conclusion, that was a rapid fire of a lot of stuff because older IBD patients require truly multidisciplinary care, but it's actually easier to get the multidisciplinary care when you're over the age of 65 because many services that are unfortunately not covered for younger patients can be covered over the age of 65. They do need closer monitoring. We need to recognize flares early and start appropriate regimens early, including surgeries in the right circumstance. One of the things that we tend to do is avoid a surgical consultation until they're really are too frail, too anemic, too weak to actually safely undergo surgery. And then we need to optimize nutritional status, physical conditioning. We need to vaccinate. And this is the important thing. We need to monitor for treatment and test exhaustion, and what should the realistic endpoints be. I just recently saw a lovely 76-year-old who's had 4 colonoscopies within the past 2 years to assess for mucosal healing. Is that the practical approach? Probably not. It may not be the practical approach for anybody, but certainly not a 76-year-old. So these are important things to keep in mind. A lot of the information, particularly on how to get services covered, are in the slides, so hopefully you'll be able to use them. Thank you.